Hello, and welcome to the Point of Care podcast. Today's topic is hypercalcemia, with a focus on the inpatient setting. As an introduction, hypercalcemia is defined by total corrected calcium over 10.5. Severe hypercalcemia is a calcium over 14, or symptoms with a calcium over 12. You have to correct calcium for albumin level. To do this, you subtract 4 minus the albumin, multiply that number by 0.8, and add that to the serum calcium that you've calculated. The most common outpatient presentation is primary hyperparathyroidism from an adenoma. The most common inpatient presentation is parathyroid hormone-related peptide. Hypercalcemia is formally diagnosed by an elevated calcium level on 2 separate samples that were taken at least 1 week apart over a 3-month time span. In terms of a checklist when you're admitting someone with hypercalcemia, to get a gut check, make sure you correct for your albumin. For admission criteria, anybody who has severe hypercalcemia requires an admission for treatment and expedited workup. When you're doing a chart check, look for a history of malignancy, whether or not they've gotten age-appropriate cancer screening, a history of renal stones, whether they have CKD, if they have any prior ICALs or PTHs in the system, and whether they take any medicines like thiazides, calcitriol, or lithium. When you actually speak to the patient, things you want to ask them about are the classic hypercalcemia symptoms, which we'll talk about later, and then any questions that might get at whether or not they have a new malignancy, such as weight loss, poor PO intake, lymphadenopathy, night sweats, blood in their stool, or smoking, among many others. The things that you absolutely can't miss is something like a new malignancy, severe disease, and AKI and renal failure secondary to their hypercalcemia. Admission orders that you can place even before you see the patient are things like a BMP, you'll need to know their creatinine and you'll need to trend it, LFTs if they're not already done so you can get an albumin to actually correct for the calcium, and an alk phos to see if they have any bony disease, as well as an ICAL, a PTH, a 125-OH vitamin D, a urinalysis to assess for if any stones, and then if you're really concerned that they have a malignancy, you can send the PTH-RP, an SPEP and a UPEP with serum-free light chains, and make sure that you order them to be strict INO, because you'll be monitoring the urine output. The initial treatment to consider, along with this initial workup, includes aggressive fluids with normal saline and calcitonin if they have very severe disease. You can also hold their thiazides, don't give them any calcium products, and consult renal or oncology if you think it's necessary. For an intake and assessment, the things to be thinking about include their history, which we already talked about a little bit, including known malignancy, new malignancy, whether they've had prior stones, and if they have CKD. Clinical, the things that we can ask them about include bone pain to assess for any metastatic deposits or any lytic lesions, whether they have any weakness, if they have stones, pain with urination or blood with urination, whether they've been having any nausea, vomiting, or anorexia, which could be associated with hypercalcemia, if they're constipated, if they notice any fatigue, or if anybody's noticed that they've been altered or confused. On exam, assess for their altered mental status, do a very good volume assessment because many of these patients present quite dehydrated, assess for abdominal tenderness or distension that could suggest constipation, and look for pain to palpation over sites of bony disease, most notably over the spine. Data that you should be thinking about and incorporating into your assessment includes an ICAL, a PTH, a vitamin D, specifically the activated form or calcitriol, and creatinine to assess for any renal dysfunction. In terms of etiology and differential diagnosis, we'll go over this in a little bit, but the main things to be thinking about are primary hyperparathyroidism, which is more commonly seen in the outpatient setting. You should really be on the lookout for malignancies when people present with severe hypercalcemia in the inpatient setting. In terms of a framework, the first branch point is whether or not the PTH is elevated or not. If it is elevated, that's most likely primary hyperparathyroidism and more commonly caused by an adenoma instead of hyperplasia. And again, this is by far the most common thing that you'll see in the outpatient setting. Other uncommon causes of an elevated PTH include a parathyroid carcinoma, MEN1 or 2, and then tertiary hyperparathyroidism like long-standing CKD. There's also the familial hypocalciuric hypercalcemia, which we're not going to talk about because it's probably not the reason why they're inpatient. Common causes of low parathyroid hormone include things like parathyroid hormone-related peptide, which is most commonly seen in squamous cell carcinomas, most commonly lung or head and neck cancers, but can also be due to renal cell carcinoma as well as breast cancer. And then another cause is lytic bone lesions, and this is most commonly seen in lung cancer, breast cancer, and multiple myeloma. And if you have these lytic bone lesions, this portends a very, very poor prognosis if it's causing hypercalcemia. Uncommon causes of a low parathyroid hormone include things like granulomatous disease, which includes sarcoid and TB, And one of the ways that you'll tell that this might be what's going on is if you see a high calcitriol, or the 125-OH vitamin D, which is the active form of vitamin D. And the other causes are lymphomas. Hodgkin's lymphoma is more likely to cause hypercalcemia instead of non-Hodgkin's lymphoma. And again, it's often driven by the active form of vitamin D. Other really uncommon causes of hypercalcemia that are caused by low PTH include vitamin D toxicity. Again, you'll need to see a very high level of the storage form, the 25-OHD. Sometimes meds like thiazides can cause it, but probably not going to be causing severe hypercalcemia. Immobilization, and this is somebody who's completely bed down, mostly due to being quadriplegic from some sort of an injury or very severe illness. You have to be immobilized for a very long time to actually see hypercalcemia from bone breakdown. Milk alkali syndrome, as well as things like hyperthyroidism and adrenal insufficiency. Once you've made your assessment and think you have an idea of what's going on, in terms of the plan, initially you can just talk about what the major workup is, which includes getting an iCal, a PTH, a vitamin D, a BMP to look for renal function, and your LFTs to look for your albumin and your alk phos. Again, if you have a low PTH or you're very highly concerned that there's a malignancy, you send the PTH-RP, an SPEP and a UPEP and serum-free light chains to be looking for a plasma cell dyscrasia like multiple myeloma. And you can consider, if you're really, really suspicious for a cancer, to look for it either a solid tumor or lytic lesions by doing a pan scan. And if you aren't really sure what's going on, you think it's primary hyperparathyroidism driven, and you are concerned that there's some sort of an adenoma that's causing this, you can consult surgery to see. The things that they would actually take the adenoma out for would be if they're symptomatic and they have primary hyperparathyroidism, or the calcium's over 11.5. They have osteoporosis or fractures. They have really bad kidney stones that are difficult to actually treat because the calcium is so high, and their age is less than 50, meaning they have a long life ahead of them. In terms of the plan for how we would treat them, the mainstay is fluids, fluids, fluids. If it's not that bad, they can probably do PO, but if they're coming in with severe hypercalcemia, they're going to need IV fluids. You should immediately, if they haven't already gotten it when in the ED, bolus them with normal saline, and then aggressively replete them with 200 to 300 cc's an hour for a goal urine output of about 100 to 150 cc's an hour. And you can diurese them if you need to. Whether or not somebody has heart failure or oliguric AKI, you can hopefully still actually give them all the fluids to protect their kidneys and just get the fluid out by diuresing them as needed. If it's very severe and they're having symptoms, you can give calcitonin, and you can give it 4 to 8 units per kilogram twice a day for 48 hours, again, if the calcium's over 14 or if they're having severe symptoms. The mainstay really for treatment is bisphosphonates, the most common one being zoledronic acid, which you can do 4 milligrams IV, or pamidronate, which is 90 milligrams IV, and these are usually given somewhere between every 3 to 4 weeks or so, depending on how long they actually last when you check their calcium levels. You do need to take these for about 2 to 4 days to take effect, and when you're doing it, you should be repleting their vitamin D. You can also consider denosumab for patients with CKD or other bisphosphonate contraindications, or if it's refractory to something like zoledronic acid after you've given them 8 milligrams. You should be avoiding any contributory medications like thiazides, lithium, and IV phosphate to the extent that you're able to. And if they're not a surgical candidate and they have primary hyperparathyroidism, again, the mainstay is probably just giving them bisphosphonates, but other options include cinacalcet and tamoxifen. But that's probably not going to be something that you're making a decision about on the inpatient setting. Some pearls to think about. Historically, the way we get most of the values was through a Chem 7, and that panel actually didn't have calcium. But now we do have it, and so we're finding a lot more incidental findings of hyper and hypocalcemia in the outpatient setting. Again, the most common outpatient presentation is primary hyperparathyroidism from an adenoma, and the most common inpatient presentation is from positive ectopic production of PTH-RP from a cancer. Again, you have to, in order to formally diagnose hypercalcemia, have to see elevated calcium levels in 2 samples 1 week apart over a 3-month time span. And primary hyperparathyroidism is usually going to show high calcium and an inappropriately normal PTH versus a high PTH. Phosphorus is often a surrogate for PTH level, and so it's usually going to be low if the hypercalcemia is driven by PTH. Calcium itself is a diuretic, and so patients often present very volume depleted, which is why volume resuscitation is so important to avoid renal injury, which limits the options for our treatment. Calcitonin quickly lowers calcium levels, which is why it's used in severe hypercalcemia. However, there's calciphylaxis, which occurs over 2 to 3 days, which is why we tend to not give it for more than 48 hours. Bisphosphonates themselves are actually more potent than calcitonin. They just take more time to work, usually on the order of 3 to 4 days. Hypercalcemia is present 20 to 30% of patients with cancer, and it's associated with a very poor prognosis secondary to advanced disease and metastases. if the cause of your severe hypercalcemia is due to bony mets alone, you really need to have a very widespread burden of disease. And of note, if your hypercalcemia is in fact driven by PTHrP and your hypercalcemia is over 12, the effect of bisphosphonates is a lot less potent and it'll probably last for a lot less time, with common relapses within 14 days, either requiring different treatment or more frequent treatment with bisphosphonates. Bisphosphonates work by leading to apoptosis of osteoclasts in our bone, and zoledronate is better than pamidronate for lowering the calcium levels in cancer patients. But it's also more likely to cause an AKI and an ATN, so you should avoid it if there's any concern for myeloma that could be causing any renal dysfunction, and should be absolutely used with caution in CKD. And the one thing that we think about a lot is the risk of osteonecrosis of the jaw and femur fractures with bisphosphonate use, but overall it's pretty rare, and it's usually only in patients who require high doses and really long-term therapy. When it comes to vitamin D-mediated processes, you should be checking 25-OHD, which is calcidiol. That's the storage form, and that's the one we use really to assess for insufficiency. When it comes to looking for the causes of hypercalcemia, you need to be looking at 125-OHD, which is calcitriol. And that's the active form. And this can get kind of confusing, but essentially just remember 125 calcitriol, that's the one you need to be looking for if you're looking for a source of the hypercalcemia. As an aside for vitamin D, ergocalciferol, which is D2, comes from plant sources. Cholecalciferol, also called D3, is formed in the skin and comes from animal sources and is more effective at actually raising levels when you supplement with it, and thus D3 is the preferred mechanism for supplementation. And the difference in this is just at the level of liver metabolism. It is more not something that we need to know about for inpatient management. Increased production of calcitriol, which is the active form of vitamin D, is the cause of the hypercalcemias that we see in Hodgkin's lymphoma and about 1/3 of cases seen in non-Hodgkin lymphoma. Again, to get hypercalcemia from immobility, it really needs to be over quite a long period of time and from either paralysis or very severe illness. We know that loop diuretics can lower calcium levels, just like thiazide diuretics can increase the levels, but they should only really be given if there's evidence of overload with heart failure or CKD, not just to lower the level of calcium. In terms of trial and literature, we'll link off to the one that we talked about showing that zoledronic acid is superior to pomidronate in hypercalcemia of malignancy, and also a few different articles that review hypercalcemia associated with cancer, as well as the diagnosis and management of hypercalcemia. Some other resources you can look out for are the excellent podcast by the Curbsiders. They have one on just hypercalcemia, and they have one on oncologic emergencies where they touch a little bit on hypercalcemia of malignancy. And as always, the Clinical Problem Solvers has an excellent diagnostic schema to think through hypercalcemia. That being said, though, I would focus on the main things whenever you're thinking about what the actual etiology is. Just be thinking if it's elevated PTH, it's probably primary hyperparathyroidism, and if it's low PTH, it's probably cancer, and it's either coming from parathyroid hormone-related peptide or lytic bone reasons. If it's not one of those two things, just look up a framework, because honestly, it's a pretty rare zebra at that point, and it's rare to begin with. So just to summarize, if you remember nothing else from this episode, remember this. Hypercalcemia is most commonly discovered incidentally in the outpatient setting, but when it's diagnosed inpatient, especially when it's severe, it needs to be taken very seriously. The most common cause of hypercalcemia in the inpatient setting is from a malignancy. After you've corrected for albumin or you've gotten an iCal, if the hypercalcemia is severe or you're having symptoms, you need to be aggressively resuscitated with normal saline to protect your kidneys and given calcitonin as a bridge to other mainstay calcium-lowering agents such as bisphosphonates, which can take 2 to 4 days to work. Overall, the prognosis, if it is related to cancer, is quite poor. The only way you can get the calcium down, truly, is to treat the cancer. And if you can't do that and you can't address the calcium, the life expectancy is unfortunately on the order of weeks to months. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.